The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. Thanks for joining us today for our webinar. My name is Carmen Boone. I'm an education coordinator from Oregon Pacific Area Health Education Center, a hosted agency of Samaritan Lebanon Community Hospital. Our agency mission is to promote access to quality health care through community and educational partnerships. Today, I will be your host and moderator. If you are experiencing audio difficulties, please make sure your computer speaker volume is turned up or use the phone option to listen in. You will see that your GoToWebinar control panel is set on mute, so all microphones are muted and they'll remain muted during this session. You may download the slides from the handouts menu in the next 10 minutes. I'm going to put them there for your availability. Use the questions menu for typing questions or comments at any time. We'll be answering the questions at the end. If we run out of time, we'll answer them via email, so you won't lose any of the answers. This webinar is being recorded and will be available on our YouTube channel. And if you have any questions, please email me at the email address that you see on your screens right now. If you are aiming to obtain CME or CE credit, please log in to www.eeds.com and enter this activity code. Please write down the activity code for your records and consider that this code will expire in 1 week. Just to make sure, keep in mind that we will email you these instructions, the code, the link, the YouTube channel, and my email address as soon as this webinar is over. So no worries if you don't get information right now. This activity is brought to you by the cooperation between Samaritan Health Services and the Oregon Pacific Area Health Education Center. The presenters and the planners of this activity report that we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. This webinar is presented by Sara Lee Thomas. She earned her bachelor's degree at Oregon State University and completed her internship and master's degree at Oklahoma State University. Sara led a national award-winning Healthy Heart team in Central Oregon for 15 years on the Warm Springs Indian Reservation before moving back over the hill to Corvallis to become the clinical nutrition manager at Good Samaritan Regional Medical Center in 2010, where she continues to educate the community, students, and professional staff on nutrition. Today, Sara will share information on the role of probiotics in healthcare. And join me congratulating Sara on her 11th anniversary at Samaritan Health Services. Thanks, Sara, for staying with us and providing all these great information and knowledge. And now, without further ado, I will send the screen to Sara and we can start our presentation right now.
Okay, well, thank you, Carmen. Welcome, everyone. I am going to discuss probiotics in healthcare with a focus on C. diff. These are some of my background information. And one of the points I want to make is I'm going to be mentioning brand names during my talk. I don't have any financial relationship. I do that because some probiotics work and some don't. I don't want people to go and get the wrong one, because getting the wrong one means you don't get the right one and don't get the right protection. So you can't assume that you can substitute one Kefir for another. There's no standard generics, unfortunately. So what we want to accomplish today is I want you to be able to define probiotics and prebiotics and give an example of each, and identify at least one indication and contraindication for probiotics in hospital care specifically. And then recommend at least one probiotic species and or a product name that is effective for the prevention of antibiotic-associated diarrhea and or C. diff. So these are the great outcomes we've had at Good Sam with the probiotic protocol. As you can see in this data from the CDC, the expected rate, the red line, is much higher than our actual rate that we've enjoyed at Good Sam. And after we fully implemented the protocol in 2013, we maintained a rate, as you can see, under 4, and this is statistically significant, the p-value under 0.03. Next, I'm going to kind of start with the end in mind. So we adapted our protocol from the Nancy's yogurt protocol from Dr. Martindale at OHSU, and you can see some details if you take this link. Then I'm starting with a little template that you could use to ask your administrative and clinical team to implement this at your hospital or care center. So let's start there. So here's a hospital-based probiotic protocol for the prevention of C. diff for hospital X. Start out with the problem. What is the problem of CDI, abbreviation for C. diff infection? According to the CDC, patients on antibiotics are 7 to 10 times more likely to get C. diff. C. diff can occur up to a month after taking the antibiotic. It can come back in 1 out of 5 patients. And most seriously, C. diff is the most deadly healthcare acquired infection. 1 out of 11 people over age 65 will die within a month after acquiring C. diff infection. It's also very high mortality in the hospital as well, 4 times higher mortality in the hospital in a patient with C. diff versus without. Hospital costs are $15,000 higher for a patient with C. diff versus one without. And the problem, our hospital rate, this hospital X, acquired C. diff rate is 7.4 cases per 10,000 patient days in 2015. Their standardized infection ratio, that's between what they have and what the national is, was no different than the national rate. And hospitals can get more up-to-date information through local access through their hospital, through the CDC NHSN network. So here we go. Here in 2015, Hospital X, these are real numbers, but I'm hiding the identity. So you can see that they had 19 cases and their C. diff was 7.4. That year at our hospital, with the Kefir protocol, our rate was 3.4, and we were statistically half of the national. So for Hospital X, about 9 cases a year can be prevented with full implementation of a probiotic protocol with the right type and amount of probiotic. So we predict that Hospital X can reduce from 7.4 to 3.9 cases per 10,000 days. This results in a cost savings of $135,000 a year. And this improves hospital care, hospital ratings, and reimbursement, and we can make a difference. What is the truth about probiotics and C. diff infection? First, hospitals represent a large and varied therapeutic class. They are not all the same. Some types of probiotics have no effect at all on C. diff. They don't work for it. Some probiotics only work when you feed them, and we probably know some people like that. So you feed them, then they can acidify the colon to a pH under 6. And once it drops below 6, C. diff doesn't like to grow. And some types of probiotics do help prevent C. diff. Here is a quick list of things, and we'll revisit this as we go. And all of these, except for Fluorostor, which is a probiotic yeast, all the rest either contain L. casei or L. rasmosis or a mixture containing them. So what's the basic protocol? If a patient's getting an antibiotic, they need a probiotic. They need to start within 2 days of taking their first antibiotic. They need to take the probiotic 2 hours apart from taking the antibiotic. And they need to continue this at least 1 week after their last dose of antibiotic and up to 4 weeks. Absolute contraindication, if someone has a milk allergy, they cannot have any milk-based probiotic. Relative contraindications, where you have to have some judgment, is if they're severely immunosuppressed. To give you an idea, this is like an absolute neutrophil count under 500, where we actually count neutropenia to be under 2,000. So this is severely immunosuppressed. One other caution, floor store the probiotic yeast. Do not open them up to put them down the feeding tube ever. They kind of spread out. They can infect ports in critically ill people, and they stay on nurses' hands even after washing. So they should only be used if the pills can be swallowed intact. So in conclusion, a hospital-based protocol is simple, safe, and effective, and can improve care, costs, and outcomes for our patients in our hospital. And here's some references. So that, in a nutshell, is the presentation you can give to get this going at your healthcare organization. And here's the Nancy's Keeper protocol. It's super difficult here. So 2 ounces once or twice a day by mouth, and that's the flavored kind. And if by tube feeding, that's orders only, but it's 1.5 ounces of plain Nancy's Keeper, diluted 50-50, and flush the tube 30 mils before and after, and twice a day. And let's revisit Hospital X. These are real numbers, but I'm not sharing the name. So after they added the Kefir protocol, they went from 19 cases to 8, a rate of 7.4 per 10,000 down to 2.8. However, some clinicians there read an article or something and thought, oh, no, we shouldn't do this. This doesn't work. And so they stopped it, unfortunately. And so when they stopped it, it went back up. So 2018, it bounced right back up to 17, and the rate was 6.4. So, and I'll talk about what they might, what I think they read, and explain why it might have been misinterpreted. George Carlin, one of my favorite comedians, diarrhea. Does that mean one enjoys it? So another theory. So let's kind of look at some introduction, outcomes, and evidence. So what are the basic, like textbook benefits of probiotics? Not controversial at all. They help the immune system, they keep the colon healthy, they downregulate allergic responses like eczema, they improve digestion and elimination, so they pretty much bring things to the middle, less constipation, less diarrhea, and we're reducing incidence of and duration of intestinal infections. One thing to know is recently, in the last year or two, they reclassified. So basically, C. diff got its Ancestry.com stats back, and it's now reclassified as Clostridium Difficile, but it's still C. diff, so we'll refer to it as C. diff. And this is very cute. He looks very worried about the Nancy's Keeper. But all kidding aside, we need to focus on why we want to do this. 1 out of 11 people 65 and older will die within a month of being diagnosed with C. diff. This is a deadly healthcare-associated infection. We need to prevent it. Let's look at this. So antibiotics have benefits, and they're used widely. A survey found about half of inpatients get an antibiotic during their stay. But does this make antibiotics, should we stop antibiotics? No. It's like any drug. It has its benefits, and it has its downside and its side effects. So how can we, because once we had antibiotics, we really reduced death from that, but we have this adverse effect. So let's will die. So if you have 100 patients treated with antibiotics, 30 get antibiotic-associated diarrhea, 10 of these 30 will be due to C. diff. So what are the standard solutions? What are the standard infection prevention? Antibiotic stewardship. Let's not use a broad spectrum antibiotic when we don't need it. So tiny holes in the UK, 40% almost 70 per 10,000 down to around 9.5. And share those success stories, CDC. So they looked at some major hospital groups that implemented these standard infection prevention bundles, and they got great results, 20–25% reductions in C. diff, down to around between 7 and 9 cases per 10,000. Doing many things well, tracking things, we're doing all the right things to prevent and control C. diff, including all of those things we mentioned. We cleaned things, we posted, we monitored hand hygiene, and we even tracked and reported on enteral dosing being adequate. So to these stable and successful efforts, we added Nancy's Kefir at the end of 2011. 2012 was our first full year. We kind of had limited orders only, and that really doesn't reach everybody you need to reach. So we expanded it in 2013, as evidenced by a 44% increase in our use of Nancy's Kefir. We did that by making it floor stock, so nurses were authorized to use it as indicated and not contraindicated for PO intake. And here we go again. And these were the results. We dropped over half in 1 year. And again, during this, you might say, well, were things, maybe something else was changing. But it wasn't. And the 5-year highlights are these benefits of the Kefir shots. So representing over 177,000 patient days, sustained reduction in CDI rate to under 4. We prevented over 50 cases of C. diff, prevented an estimated 4 deaths, and saved over $800,000 with a return on investment of 31 to 1. So for every dollar spent on Nancy's Kefir, we saved around average of $31. And that's up to $200,000 saved annually by avoiding CDI cases. And we call these Kefir shots, and one of the nurses started that because it's 1.5 to 2 ounces, so a little shot of Kefir. And some additional notes for those who want some of the details about allergy and intolerances and gluten-free and alcohol-free. And additional details on Nancy's Kefir. Some details are proprietary. These are the ones I can share. And so Nancy's Kefir can be classified as a mixed probiotic or a symbiotic or firmbiotic. Those are different terms for probiotics. And the levels stay very high throughout shelf life. So 45 mils of plain Kefir or 60 mils of flavored will have at least 10 billion CFUs of probiotics throughout shelf life. So I classify it as broad spectrum. It also is similar to some products that have been found effective for preventing antibiotic-associated diarrhea, as well as restoring the patient's normal microbiome. So one concern is like, okay, you disrupt the microbiome, can you restore it? And BB12 and LA5, while they don't fight against C. diff, they do help the patient's system get back to normal. So C. diff prevention is not the only reason we use Nancy's Kefir. It's useful to track the C. diff because the CDC does it for us, but the pathogenic cause of most antibiotic-associated diarrhea is not known. But Nancy's Kefir has probiotics that are effective. So if you're on an antibiotic, you need a probiotic. And these are some additional details on like L-Casei, which is against E. coli, Salmonella, Shigella, Listeria, intestinal viruses, including rotavirus. So, and I'm repeating this because I want these points to be driven home. Probiotics are not a one thing. You can't ask, do probiotics work or not? That's like asking, do injectable medicines work or not? It depends. For what and what purpose? Again, some type of probiotics, guess what? They don't have any effect. They don't work on C. diff. Some only work if you feed them. And some probiotics do help prevent C. diff, but guess what? No surprise, dose matters and timing matters. And this is what I think triggered that other Hospital X to stop their probiotic protocol, even though they had local evidence that it was working. There was a very large randomized trial of nearly 3,000 older adults in the hospital who received probiotics, Acidophilus bifidobacterium, and they didn't have any effect. So this is large, randomized. So up to date, concluding that this trial, suggests that routine probiotics may not be effective. And this is, again, the misinterpretation of probiotics. Do probiotics work or not is a wrong question. The accurate conclusion was that these 2 specific species were not effective as used in this study. So again, probiotics are a therapeutic class. They're not a monolithic therapeutic agent, and they can be as different from each other as this dog and this turtle. Another factor was they used species that hadn't been found effective on their own before. They didn't have L-Casei, didn't have L. rasmosus, and then the ones they did use, the only times they might work is if you feed them. Those are species that if you feed them, they make the colon acidic, and that inhibits C. diff growth. So in this case, they were basically giving guns without the bullets, and no surprise, it wasn't effective. Additionally, Cochrane review later found that they had extraordinary low baseline risk, and so made this study, although very large, made it underpowered, even though it appeared to be large. So what about prebiotics? What are prebiotics? It's confusing. So probiotics are alive and need to eat, and the food they eat is called prebiotics. Just think of Popeye. Popeye is like the probiotic. The spinach is like the prebiotic. So Popeye gains his powers after he eats the spinach. So again, some probiotics do nothing to treat or prevent C. diff unless they're fed. And probiotic benefits can be disease and species specific, but sometimes even strain specific. So if your indication is you want a lap dog, you may want the little Chihuahua, but everybody's different. And this is just a picture. I'm not going to go over in detail. I just want to impress you the huge diversity. We start out with 4 phyla, and all of these have families and species and subspecies and strains. So saying probiotics work or not, all of these, well, except for the pathogenic ones, are candidates to be probiotics, and certainly they vary from each other. This is a classic example. I love this study because only if you looked at the placebo and the B. lactis BB12, which is the yellow, you'd conclude probiotics don't work. Probiotics don't keep babies healthy and away from physician visits and extra antibiotic prescriptions. They don't work, but that's wrong. That's saying BB12 doesn't do that. But if you look at L. reuteri, yep, it's highly significant to keep babies healthy, in daycare, not missing it, and not needing clinic visits. So different bugs for different jobs, just like there's different drugs for different jobs. So here's our cheat sheet. L-rasmosis, 10 billion, once or twice a day. Aspergillosis, the yeast, 250 milligrams twice a day. Dan active, which is L-casein, a couple times a day. And mixed probiotics, which includes Nancy's Kefir and BioK drinks and pills. Also, I added one for this version for L-plantarum, which was used in very high-risk nephrology and transplant patients and was found safe and effective. But this was a before and after observation and not a randomized controlled trial. And here's the picture. 2 a day, keep the C. diff away. That's what the products look like. L-culturel, Florastor, Dan active, Nancy's Kefir yogurt. And this is BioK, which was used over 10 years to drop C. diff rate from 18 down to 2.7, highly significant, and maintaining a rate much lower than neighboring non-protocol hospitals, a 2.7 rate versus 8.5. And it was used like a blanket way. If you were on an antibiotic, you got 1 capsule a day. If you're an older patient, you got 2, and they had 10 years of data. So again, basic protocol. Start the right kind and dose within 2 days. Take it 2 hours apart from antibiotic and keep taking it. So we need to conclude here before we go on. It does work. It is safe and effective. It is low cost, high reward, and there is a high risk if we don't do something. 1 out of 11 seniors will die within 30 days if they get C. diff. So let's take a next step to generate out some more information so you kind of understand the context of what we're talking about. So you and your microbiome, each of us has trillions of bacteria and microorganisms living on us and in us, about 3 to 4 pounds. This is normal. It's about the same number of cells as our body, so they match us cell for cell, but they have many, many times more genes. This so-called microbiome is a normal and important part of our health, nutrition, metabolism, and immune system. If you took your GI tract and spread out the entire area, it'd be the size of a tennis court. And all of this is associated with lymphoid tissue or immune cell. So your immune system in your GI tract accounts for over 70% of your immune system. It interacts with your probiotics that are in your gut. And so maintaining this so-called lawn in shape requires the right food, the right probiotics, which can be disrupted by various things that happen to us in life. So let's start at the beginning, the beginning. At birth, whether a child is born vaginally or C-section affects what bugs they pick up. Those who are born by C-section tend to have a different microflora. They pick up more from the skin, and that leads to increased risk of allergies and childhood overweight. Breastfed versus not, even if you start the first hour or don't, can affect. It's very beneficial to the microbiome to be breastfed. And then as the child gets older, up to 18 months, they pick up variation based on their diet, dirts, pets, all are good things. for the most part. And until about 18 months old, our microbiome is fairly well established. And if we take probiotics, they pretty much end up being 2-week guests. They're there and they're gone. So it becomes pretty stable. And again, your microbiome would weigh about 3 pounds if you added it all up, and they match us 1-for-1. So we're basically, I'm half microbiome. And you can disrupt it though. Antibiotics are one of the worst, but again, we can control for that side effect. Age, over age 65 or something, we lose diversity in number, and stress and sleep and trauma. Now, a lot of times our microbiome can bounce back, but if we have several of these courses of antibiotics or several of these things together, it can be damage the microbiome. And the appendix to the rescue. The appendix, it turns out, is not a useless organ. It actually acts as a literal appendix to have a safe hiding place for your microbiome. So if something happens like severe diarrhea, your microbiome can repopulate itself from this little appendix of safe microbiome that can spread from the appendix. So the appendix is not useless, and it's quite an interesting thing to find out. So what are the terms that we're going to go over? Some basics: probiotics, prebiotics, and symbiotics, and colony-forming units, and mechanisms of action. So for colony-forming units, that's just a measure of how many little bugs. If you dilute it all down, and one little bug can grow a family, that's a colony-forming unit. So it's a literal count of how many probiotics are in something. Common mechanisms of action are just like musical chairs. I'm here, you can't be here. So the fact that you have probiotics and a healthy microbiome means that bad bugs don't get a way in. And sometimes it can be very specific, like Fluorostor, Saccharomyces boulardii, specifically targets C. diff and prevents it from binding to your gut and breaks down the toxin C. diff makes. So it can be common or specific. There's a lot, though, that we need to know. Some things we know for sure. There are probiotics that prevent antibiotic-associated diarrhea and C. diff. There's a lot of diseases out there that you'll see extraordinary claims on. Hey, it prevents this or that. Some of those are in very, very early study. We can't plant a flag on them yet. And so there's lots of research going on. So there's things we do know and things we don't. Let's illustrate these ideas. One idea is you fight fire with fire. What can fight better another bug than another bug? They basically pick on someone your own size. And then grandchildren in about an hour. The generations are very fast for bacteria, for instance. If you have a bacteria on your lunch and you leave it at room temperature, it will double in about a half hour and then double again in another half hour. So a bacteria can have grandchildren in about an hour. So they can rapidly adjust and compete. And you are eating for two. You're eating for yourself and you're eating for your bug buds. Things that you can't digest end up being their food, like fiber. And the best example I've come up with illustrating what a symbiotic is it's like if you had a chicken farm and you wanted more chickens. You can get more chickens by getting more, so go buy some more chickens, or you can just feed the ones you have, or both. So when you do both, when you take a probiotic and you take a prebiotic or eat more soluble fiber, that's symbiotic, and that is best for the best results, especially for certain probiotics. So if you're going to send in the army, you need to pack them a lunch. If you're going to give them some guns, you probably should give them some bullets too, because otherwise some probiotics are, they don't work. It's like, well, you gave me an unfunded mandate. You want me to do something, fight a disease? Well, you got to feed me, or if you want me to shoot that, you give me some bullets. So it's important to understand that probiotics are alive and they need to eat. So keeping it simple, probiotics, the good bacteria, although again, some are yeast and they're alive and you need a certain amount to have a benefit. And these are, as a reminder, these are the standard textbook. We know they do these things. Here's a great example. LKCI, which is Dan active twice a day within 48 hours of starting an antibiotic in the hospital. They reduce the risk of both. In fact, the number needed to treat was between 5 and 6. The lower the number needs to treat, the better, because a number needed to treat means you only have to give 6 patients this intervention, and you prevent 1 case of C. diff that the placebo person would have otherwise got. So the lower the better. This is a super impressive number needed to treat. And it was low risk. They had no adverse events. Prebiotics, it's the good food for the good bacteria. So these are things that they can ferment or eat, which fuel their growth, so more chickens on the chicken farm, and help them do things. Probiotics produce compounds that are antibiotic or improve all kinds of things. So in this case, the apples will probably give you more prebiotics than the apple juice because they have more fiber. So here are some details. One of the main compounds from prebiotics is they turn into short-chain fatty acids, which I mentioned make the colon more acidic, and then C. diff can't grow, and other bad bugs can't grow. But they do a whole lot more. Immune system, blood sugar control, cell proliferation, and so forth. Prebiotics are primarily soluble fiber and complex sugars like inulin, oligosaccharides, artificial sugars like lactulose, plus insoluble fibers to a lesser extent. But also some phytochemicals produce food for them as well. So again, understand what probiotics and prebiotics are. Probiotics are alive and need to eat. And when you give them what they need to eat, they do a great job. And here is a little sequence that you can follow. So short-chain fructooligosaccharides is a special kind of prebiotic that is no residue. It's completely eaten up by bifidobacteria. They turn it into short-chain fatty acids. These actually add fuel, so actual calories to the colon. C. diff likes to grow around a pH of 6.5. The pH drop below Sara, but it sounds a little fringe. You know, it's not fringe. This is actually recommended by Imaging Society guidelines put out by Aspen and the Society for Critical Care. The routine use of soluble fiber should be considered in all ICU patients as a prophylactic measure to help maintain commensal microbiota and promote bowel health. Appropriate dose would be 10 to 20 grams divided over 24 hours. So we want to maintain our microbiome even, or most especially in critical illness. So keep it healthy. And this was one patient's story. I need to be mindful of my time, so I'll kind of go through it quickly. This patient had severe watery diarrhea. They couldn't find a pathogenic cause. She'd been to the doctor many times. Her pain score was way high, like sometimes fetal position, and gave her that Nutriflora, and I'm using the brand name because it's branded, it's sold under different brands, but within 24 hours, her diarrhea was gone and her pain was cut in half. And this is the amount that is effective. And here's some data if you're interested. Again, Nutriflora is the company that created the little short chain stuff, so they get their brand name, but they sell it under other brands like Now and Swanson's and so forth. So just a reminder, prebiotics. Nutrition is important for them as well. And this is not new either. It's like, okay, what's new? It's exciting. This company made something. No, it's from the beginning. Breastfed bacteria. Human milk contains 5,000 to 15,000 milligrams per liter of breast milk. Not provide a single calorie to the baby. So why go to the trouble of making so much? Because it's not meant to feed the baby. It's meant to feed the baby's friend. It only feeds one specific bacteria, Bifidobacterium infantis. And if a baby's breastfed, Bifido rules the stool at 12 weeks, and it's very protective against necrotizing enterocolitis. This is why breastfed babies have half the risk. And they have isolated this, and they sell it in the brand name Align, is the only one that actually put under investigation. The problem was this whole study started out, the group that ended up being assigned probiotics started out with triple the amounts of multi-organ failure. Well, if you have multi-organ failure, the mortality is going to be higher. And so actually, if you look at what changed over the time of the study, the probiotic group, although it started out with more, it ended up relatively with only about 70% more than it started out with, whereas the control group with no probiotics actually ended up getting 150% more people with multi-organ failure. So actually you might say, maybe it's not as clear-cut as we thought. But most concerning is insoluble fiber is not meant to be given to critically ill patients, but in this study that they did on critically ill patients, they used an intro formula that could give the patients up to 21 grams of insoluble fiber daily. This is inappropriate. So let's pause before we move on to the next topic. What do we know and what don't we know? We know that probiotics in food are generally recognized as safe. We know certain probiotics can reduce the risk of antibiotic-associated diarrhea and C. diff. We know fermentable soluble fibers, 3 to 20 grams, do lower LDL cholesterol. That's A-level strong evidence. And we know they are prebiotic. We do know that soluble fiber is recommended routinely for ICU patients, 10 to 20 grams a day standard. And we know that dietary fiber has many health benefits. And we also know some people don't tolerate some kinds of prebiotics. So you can Google to learn more. But as a tip, hydrolyzed guar gum does not bother people with FODMAP GI sensitivities. And what we don't know yet, we don't know a lot yet. We're still learning. So we do know some things, but we're still learning. And so let's, as we switch over to, okay, you have these great outcomes, Sara. Show me more. So it started with the CDC in 2012, deciding that Oregon hospitals had been required to report all positive C. diff specimens. So they all got reported, and CDC applied their protocol to determine, was it hospital acquired or present on admission? And here were the results. This is our data of our rates based on CDC data, and it was significantly reduced. And this is our protocol, pretty simple. And again, Nancy's Kefir, as a reminder, it's broad spectrum, so there's lots of benefits to taking it. And here are the details if you want to get into the detailed math of the actual cases we had each year, the expected cases, patient days, our standardized infection ratios, and our rates and the p-values. So here's the details if you want to dig into that. And also if you want to know how to calculate your C. diff rate for 10,000 patient days, I've included that math for you, an example. So again, sometimes people say, well, no, Sara, there must have been something else. Maybe cleaning changed or hand hygiene changed. And these things are important. Quarters where our C. diff rate went up were associated with where hand hygiene fell off that quarter. So these things still matter, absolutely. They're all part of the picture. But these were stable and excellent as background confounders. As you see, that kind of stayed pretty stable as our rate dropped. Antibiotic stewardship monthly workload was cut in half. In 2012, we had limited the implementation of our Kefir protocol, 260 consults. In 2013, it was cut in half. Pays the bonus. And they things in that. Also kicked it off, that she wasn't really seeing any of the complex systemic yeast infections anymore that she had seen for prior to this. And Lactobacillus acidophilus, which is in Nancy's Kefir, does have some evidence for being anti-pathogenic yeast. One huge benefit is a couple of years in, we started doing Kefir swabs, because if you're on a ventilator and you're on a tube, your mouth microbiome doesn't get any of the probiotics like you would do if you were swallowing it by mouth. And so by keeping probiotics there, the good probiotics to fight off the bad probiotics, especially L-rasmosis, which is known to adhere to the oral mucosa. We dropped our ventilator-associated effects down to 0 1 year. So we were expected to have 5 to 6 per 1,000 vent days. We only had 0 to 1 per 1,000 vent days. And this is based on the research out there that used L-rasmosis to drop VAP rates in half. And you might say, well, maybe something else was going on. No, our sister hospital that had otherwise same protocols, they were no different than the national benchmark in 2013, while we were about half. But maybe different hospitals. Well, we compared ourselves to another level 2 trauma center, and they were worse and didn't have the probiotic protocol. And then you could say, well, what about background changes? Maybe Oregon's just better. Yeah, we're better. I'm teasing, but actually Oregon did have a lower rate of C. diff overall than some other states. But from 2012 to 2013, they actually went up 10%. So it wasn't a background change. It was a difference at Good Sam. And 1 year I looked at all the data. It took a lot of time. But of the 60 reporting hospitals in Oregon, only 8 hospitals had C. diff rates better than the national rate. And all 8 of them used a probiotic protocol, mostly Nancy's Kefir or Nancy's yogurt, but also Dan Active. So let's go to Albany, back to our sister hospital. When they implemented the Kefir, they dropped from 7.4 down to 1. They did it even better. So they did an excellent job. In fact, 1 year they were given the least infected hospital in Oregon. So they did an awesome job implementing it and made a huge difference. And they put it on the tray. So this was actually even better model that they did. They put it on the breakfast and dinner tray every day for those patients who needed it. And if they didn't like it, they would put it into a smoothie. So this is how effective the Albany was. Huge drop, 7.4 down to 1, just very fantastic. And then came 2017 when I wasn't so happy with the CDC. They basically reset the line that we had to meet. So the effect was the standard infection rates will look worse even if you're doing just as good. And if you look at that, lo and behold, we were doing just as well. Our rate was 3.7, but now they're saying, oh, you should be 5.6. So it made us look like we were somehow suddenly doing worse and when we were not. So let's look at the research for those of you, the fellow geeks and math nerds that want to see, show me the evidence and answer my concerns. So here's a summary. So again, you need about 10 billion CFUs of probiotics once or twice a day. It's associated in several meta-analysis with about 40 to 60% reduction in antibiotic-associated diarrhea. And this is given level 1 or 2, A, B, high, moderate. Mostly on the high side that it does is well evidence-based. Number needed, treat of 13. 13 patients with probiotics of the right kind, you prevent 1 case of antibiotic-associated diarrhea. For C. diff, it gets a little bit more picky because we're talking about a specific pathogen. So there's some specific differences. Some probiotics work and some don't. 40 to 66, 70% reduction in C. diff if you get the right one, but some don't. And then the reduction in VAP was, we had about an 85% reduction in VAP with ours, but this is very complex emerging evidence. In my professional opinion, it makes a difference. The oral swabs is the difference. If you have the oral swabs, you're producing local protection for local bugs that could produce biofilms, aspirate into the lungs, and cause issues. And we do this in vent patients if they're not trachs and they're on high-low suction. So, and just for those who can read this literature and it gets confusing, so this is just for your reference of what 10 times 10 to the 9 means 10 billion. So meta-analysis in JAMA, this is about 12,000 patients, 82 randomized controlled trials, list of specific pathogens, and this is the evidence for that. And then again, a more closer look at just C. diff, you get a reduction again to specific species and it's safe. These studies remain safe, no difference in adverse effects, no bad outcomes. But then you dig into it a little further. Well, which ones work? So multiple species work better than single. If you look at specific ones, you look at LKCI and L-rasmosis and Saccharomyces boulardii. and dose matters. That's one issue when people read like, oh, I read a meta-analysis and it doesn't work. It's like some meta-analysis literally did all species at all doses. And that ignores one of the first principles of evidence-based medicine, which is biological plausibility. Does it ever make any sense that dose doesn't matter? Nowhere in biology that I know of. So but probiotics are a new field. We're still getting our arms around it. It's a huge and complex field, and it's a very exciting one for the future, excuse me. So let's boil this down. The mix matters. So mixed is more effective than single. Dose matters. 66% reduction versus 39% if you have the higher dose versus the lower. And timing matters. If you start a probiotic within 2 days, you get nearly 70% reduction in C. diff. If you wait, it's 30%. So you can have the same probiotic and make it twice as effective, more than twice as effective if you start it within 2 days. And this is high quality evidence for this. And Cochrane review, they're kind of like conservative, right down the road. They diff, 4,200 subjects, 23 trials. The next one, yes, about 60% reduction from about 8,700 subjects in 31 trials. And both conclusions were moderate. And probiotics matter. So this was a high quality study. CDI risk dropped over 50% with no adverse effects, highly significant, over 6,000 subjects. So what do we look at? Specifically for prevention of C. diff, number needed to treat of 6 to 10 for Dan-active, Cultural, and Espelardi. And again, I'm throwing in the details on the L-plantarum. L-plantarum is helpful for pancreatitis, and in this observation trial, it was effective for preventing C. diff in high-risk nephrology and transplant patients. So it might be worth a look. And treatment, though, it's important to distinguish between prevention and treatment. While prevention, there's several probiotic species and mixes that are found effective. None of them have been found effective, the bacterial-based ones, for the treatment. So a patient has C. diff, what do you give them? So far, the main evidence is for fecal transplants. So number need to treat of 2, it's highly effective for treating recurrent C. diff infection. But the probiotic yeast, Espelardi, Fluorostor, is pretty effective as well for reducing recurrent. And then question mark prebiotic. They haven't done a lot of research on the short-chain fruit oligosaccharides, but we do know that it can acidify the colon and inhibit C. diff. So certainly helps a person recover from C. diff. And here's the details. Espelardi, it breaks down the toxins, it reduces the binding. It's an adjunct therapy. It's not a replacement. It's not a sole therapy. So a person might be on vancomycin plus Espelardi. And then if you're interested in learning how to calculate numbers needed to treat, I've included that here. And what about safety? Most studies find no difference in adverse effects. Most probiotics are generally recognized as safe. For Lactobacillus bacteremia, there's only been 180 cases in 30 years that they reviewed. And endocarditis, only 69 cases in 30 years, most L-rasmosis. These are interventions. Again, like antibiotics have adverse effects, it's possible for probiotics to have adverse effects, of course. But we certainly tolerate adverse effects from blood thinners, and we don't stop using them. And so while there is some tiny but real risk, the benefits far outweigh that for the vast majority of patients. And Europe and Asia has had over 200 billion doses and reported less than 30 adverse effects. The other thing you have to remember is they're already there. Just because you get a Lactobacillus bacteremia does not mean it actually came from the probiotic that had lactobacillus in it. This was shown in a Finland study where they introduced the L-rasmosis probiotic, and scientists reviewed all cases of bacteremia that occurred, over 3,000 cases. They only found 8 cases of bacteremia caused by lactobacilli, but when they investigated, none of those lactobacilli were the strain that was used in the probiotic. And likewise, at Good Sam, our surveillance has found no hospital-associated lactobacillus bacteremia since we've done our probiotic protocol. It's safe. And I just want to repeat the cautions on Fluorostor, which is the yeast. Do not break them open. It can spread. And one bonus is Fluorostor is effective for traveler's diarrhea. And one of my staff a while ago, I gave her Fluorostor for her honeymoon. So a little bit funny, but I'm sure anybody going on a trip would appreciate not getting diarrhea during it. Jarrow, by the way, has good quality probiotics that is much cheaper than Fluorostor. Fluorostor can be on the pricey side. And what about supplements versus foods? Supplement quality has gotten better, but you have less of a guarantee of quality in general than with food. But they have gotten a lot better. And of course, some probiotics are quite good quality. So it's not, is it food versus pills? Be more cautious with pills, get some guidance. But there's some that are good on both sides. So what do we know? We know that probiotics and foods are safe. We know some probiotics help protect us against C. diff. We know soluble fiber helps lower cholesterol and is recommended for ICU patients. Fiber is good for many things. But we don't know some things either. So there's many things we still want to learn. And so, again, I just want to drive this home. Probiotics are not one thing. They are probiotic. They are a class of interventions. Species are different by definitions. Some work, some don't. Some will work for one thing, but not another. And some demand to be fed. And some probiotics who do work for C. diff, the dose matters and the timing matters. And here's our cheat sheet again. And a reminder that these are all different. They can be used different as two different kinds of dogs or as different as the turtle and the dog. And I look at the evidence on C. diff, I see that it's a species effect and not a strain effect. I'm sure some of these companies would disagree with me, but in my observations, the L-rasmosis is different in BioK, Culturelle, Nancy's Kefir, and they all effective. So I don't think it's a strain-specific effect, at least for C. diff. And the LKCI that's in Dan Active, Nancy's Kefir, and BioK, they're different from each other. So again, a species effect and not a strain effect. So in this case, you need a dog, and any dog will do. It'll pull your sled. So let's go over the objectives. Be able to define a probiotic. So Dan Active, it's a good bug. Dan Active, 2 bottles a day. Prebiotics is good food for good bugs, like short-chain fructooligosaccharides. One indication, if someone's on antibiotic, they need a probiotic. And contraindication, if they have a dairy allergy, they absolutely cannot have any milk-based probiotic. And recommend at least one. And here we go, Dan Active, 2 bottles a day. So there it would be. And let's see, a hospital recently in Georgia adopted the probiotic protocol from Good Sam, and they are complete heroes for zero harm. They have dropped, this is Upson Regional Medical Center, they went from 10 cases of hospital-acquired C. diff a year down to 0, and they're still at 0 16 months later. It's totally amazing. And how do they do it? 1 bottle on the breakfast tray and 1 at dinner, serving up protection. And the chief nursing officer has found this to be a really integral part of our success. Again, but it's part of the whole picture. It's part of pharmacy and nursing and infection control. It's all together. You can't have, it's a part of the puzzle. And sometimes you can do excellent work with the other. And this is that last missing piece of the puzzle that just enhances everything. So fantastic work by everyone to get this down to 0. And updated staff education, testing, and really excellent results. And this is Danny McBride, their director, who found just really amazing with how well this worked for them. And the extra mile, Dawn McCoy, who's my colleague, another clinical nutrition manager, she also shared this protocol with the nursing homes in town. And Danny McBride, the infection prevention, noticed that they were having reduced community-acquired C. diff. So people weren't showing up in the hospital with C. diff either. Why did we do this? Why does this matter? The hero for zero harm. A staff member at their hospital said, I want to thank you guys for being on the front line with the probiotics. My grandfather died from a C. diff infection. It is great to know that our hospital is trying to prevent it. You can protect patients and you can help your hospital do it. I encourage you to do so because it works, it's safe and effective, and there's a high risk if we don't do it. So thank you, and I'll open it up for questions.
Thank you so much, Sarah.
You're welcome.
Now,
And my PowerPoint, for those who want to know about other things, I have a supplemental information on what works for what, like eczema and H. pylori and staph infections and so forth.
great. And you can download the slides from the handout section on the GoToWebinar YouTube panel. Sorry, on the GoToWebinar panel. And I'll be emailing you the links to get your certificates. And when you sign in to get your certificates, you will be able to download the slides as well. Now, let's go over some items to keep in mind while you write your comments and questions. And first, you will receive detailed information and instructions on how to get your credit via email, like 2 hours from now. And the activity code expires in 1 week. Please claim your certificate so you are able to complete the program evaluation. Feel free to reach out to me or our office if you have any questions or concerns. We'll be happy to be of assistance. And the recordings are going to be on our YouTube channel. And now, again, for the ones that are looking forward to your CME or C credit or attendance certificate, remember there is an activity code, and you need to enter to www.eeds.com and enter the code that you see on your screen right now. Please write it down. I'm gonna leave it on the screen there for you. And let's start with the comments and questions. So Sarah, we have a question here. It says, what about providing the Kefir for the antibiotic Rifimax? It is minimally absorbed in the gut.
Well, there are variations. That's a good point. Probiotics and antibiotics. Antibiotics have different risks. Some are more risky than others. However, even some IV antibiotics, if they're recirculated, intrahepatic recirculation, they still impact the gut and the microbiome. So the best principle is if someone's on an antibiotic, they get a probiotic. We've had, but you're right, some antibiotics are less risky than others.
All right.
But if you have it, yeah.
Thank you for your answer. I have another question. Can you speak a bit about necessity of refrigeration of probiotics? There seems to be a lot of conflicting information on this.
Yes, it varies based on the probiotics. Like some form kind of like spore type things, like B coagulans. They don't need to be refrigerated because they just kind of curl up and kind of hibernate, so they're like fine at room temperature. And others will just be destroyed. And others, it's wrong to refrigerate them because it actually, if they're not well sealed, moisture will get in and it'll wake them up, and then oh, I'm awake, but there's nothing to eat, and then they die. So it's basically follow what the bottle says. If it says refrigerate, refrigerate it. If it says not, don't. That's my answer.
Thank you so much, Sarah. We are getting thanks and kudos for the presentation.
Thank you.
Thank you so much. And I don't see any more questions right now. Everybody remember, if you have any questions come up later, feel free to send us an email. Sarah, we're getting another comment. Very fascinating. Thank you for your presentation.
Oh, thank you.
And so we don't have more questions for now. And so thanks to you, Sarah, for being our speaker today and sharing your time and knowledge with us. Thank you
You're very
all.
welcome.
Thank you all for your participation today. And now we have completed the session and you may disconnect. Have a great day.
Yes, everybody, thank you. Have a great day. Bye,
Goodbye.
Carmen.
Bye.